Hello and welcome to today's review. Today we are going to look at a BSN NCK past paper. That was paper 1. That was done in 2017, right? And these are some of the questions that were tested. Let's look at question 1. Glycolytic pathway is located in the... Alright guys, this question was coming from cell biology testing and I hope you have done most of them. Right? Remember, glycolytic pathway is a process whereby glucose is broken down to produce energy in the form of ATP. So if you're trying to look at this option, the best result will be the cytosol, the cell cytoplasm. That's where those processes are going to be taking place. Maybe here respiration, if you're talking about respiration, maybe nucleus, maybe protein synthesis, right? Okay, DNA replication. All right. Okay. Amino acids are joined together into a protein chain by... Ladies and gentlemen, I've tried to look at these questions and I can't see any answer among this one, right? Maybe for me, I'll be happy if there was an option on peptide, the peptide chains, right? Remember, hydrogen bonds maybe will be found in the DNA. DNA polymerase is the one that's responsible for DNA replication. Transfer RNA is the one that carries amino acids, while messenger RNA is the one that at least codes the protein. So peptides here was the best answer that was missing. As must have been 3-mark question, right? The effect of insulin on glucose transport is to insulin, right? Right. Wherever insulin goes, glucose goes. You know that? Yes. So it enhances transport across the cell membrane, right? Enhances transport of glucose across the cell membrane, right? Remember, option A, glucose transport typically occurs down to its concentration gradient, not against, right? Option C, glucose transported into the brain is normally facilitated by the GLUT1 transporters. Okay, let's look at option number 4. Podocytes are located in the visceral layer of the... All right. Of course, the nephron is the functional unit. Capillaries, these are just glomerulus. These are just capillaries. The renal is the fibrous layer. The Bowman capsule or Bowman capsule is where you find these podocyte cells. Hypokalemia causes hyperpolarization of a cell membrane, right? Hyperpolarization of a cell membrane. If you're looking at option D, decreasing membrane potential, that means indicates depolarization, right? It should be hyperpolarization. Stimulation of the sodium, this reduces, right? So hyperpolarization, right? Lymph capillaries. Lymph capillaries differ from systemic capillaries in that Princess says they are less, they should be more, right? This is what makes this option wrong. They are lined with endothelium. They are not. It says they are not. It should be they are lined with endothelium. They have valves, right? Yes. Best option here is B. They are absent in the central nervous system. The most appropriate position to place a patient who has undergone supratentorial craniotomy is... Remember, we want to elevate the head and to reduce intracranial pressure while promoting venous drainage and decreasing the risk of complications such as the aspiration. So the best position for us here will be this one, right? And you can view this link on how to put a patient in semi-Fowler's position. A child who has a diagnosis of interception is likely to present with interception, severe colic, abdominal pains. Remember, ribbon-like stools will be associated with Hirschsprung disease. Severe projectile vomiting, this one is associated with the pyloric stenosis. Watery diarrhea is seen in commonly in viral gastroenteritis, like the infection caused by the rotavirus and the norovirus, cholera, E. coli, right, and so on. Colic, abdominal pain associated with interception, bowel obstructions, gallstones, and kidney stones. The immediate care of an 8-year-old who has undergone cardiac catheterization via the femoral vein includes, this is number 8, right? I think keeping the affected limb straight so the next 1 hour will be better. Will be the best intervention for this one. When you look at front position, it should be flat lying, right? Assessing incision, yeah, but not the most immediate priority in this case. Elevated, we are saying should be somehow flat or slightly elevated. 30 to 45, this a bit. Laryngotrachea bronchitis is characterized by a cough that is yeah, if you're looking at the stridor, it's Bachy cough, right? It's Bachy cough. The major mechanism involved in neurogenic shock is the neurogenic shock. It's going to cause what? Vasodilation, right? So going to cause vasodilation. Allergic reaction is associated with anaphylactic shock. Cardiac pump failure with cardiogenic shock, while septicemia, septic shock. The antidote for heparin sulfate is called heparin sulfate, right? Protamine sulfate, right? Remember, if you're talking about the vitamin K, that will be warfarin. Sodium chloride is normally used to treat hypokalemia, while aminocaproic acid is used to treat excessive bleeding. Though this one is an antifibrinolytic, right? Okay. The most important parameters to focus on when monitoring a patient's response to total parenteral nutrition therapy includes, all right, of course, in parenteral nutrition, we are monitoring the nutritional status, the fluid balance, and complications, right? Looking at this one, nutritional status, we look in terms of weight, fluid balance in terms of the blood pressure, and complication, probably infections and temperature, right? So if you look at this, I think we have the best option as written. Yeah, D. This is better. Temperature and blood pressure. Temperature and blood pressure may be slightly prioritized due to the immediate risk of fluid status and infections associated with total parenteral nutrition, right? Okay. The plan of a patient with Graves' disease, plan care for a patient with Graves' disease includes Graves' disease, this is hyperthyroid, okay, condition. The best one for us is D. Providing extra blankets, remember these guys are heat intolerant, right? So you don't need to do that. High fiber, patients already have diarrhea because of the super active GI. Encouraging the patient to participate in mind stimulating. Patients are already restless, anxious, and irritable, so you don't need to do that. To prevent lipodystrophy, a client on insulin therapy is advised to. Lipodystrophy is abnormal distribution of fat tissues. I think to prevent that, you could rotate the size of injections, right? The size of injections. Remember, cleaning will be important for the IPC. Aspirating blood prior to injection, not really recommended. We have, of course, advocate for locating the correct site and performing the Z technique. Administering at 35 angle, no, it should be at least 90 degrees or 45 for those who have insufficient subcutaneous tissue. A diet that will be appropriate for a patient with Addison disease. Addison disease, this Addison insufficiency, so low sodium, so you have to give them high sodium to compensate for that. Right? High potassium you avoid because they have high potassium already. Low protein, just ensure they have a balanced diet. A safety measure that's applicable to a client with cranial number 3 impairment is cranial number 3 impairment is oculomotor nerve, which controls eye movement, eyelid elevation, and pupil constriction. Looking at our option here, D is all about peripheral neuropathy. B about hearing impairments. I think C will be the best option for us. Moving obstacles in the path for that. When communicating with a client whose hearing is diminished, what are you supposed to do? You just need to speak in a normal tone, right? Just a normal tone. Just a normal tone. Because if you do it lightly, it will be uncomfortable with the patient and may distort information. So you have to do it in a normal tone while facing the client. Slowly can be seen to be unnatural, so it will be difficult for the patient to do the lip reading. Directly into impaired ear, you need to face the client so that the client can do lip reading, look at your gestures and sometimes the facial expression, right? The risk of recurrent cystitis in women can be reduced by I think urinating immediately after sexual intercourse. That can work, right? That can work. Remember, when you use tub bath rather than showers, tub bath can introduce some bacteria. So this is a risk factor. Wiping the perineum, it should be from front to back and not the other way. Wearing synthetic garments, of course, synthetic garments normally trap moisture. So instead, you're supposed to use cotton underwear, which is the one that is normally recommended. An acute asthmatic attack is treated with acute asthmatic attack. In most cases, it's better to adrenergic agonists, especially the SABAs. A link will be popping up to check on the drugs, right, that is indicated. Corticosteroid is used just to a continuous management. Same to mast cell and leukotriene, right? Leukotriene modifier, mast cell stabilizer, corticosteroids, they are anti-inflammatory. So treatment in attack, we use a bronchodilator, all right? Okay. So first line, these are beta-2 agonists, albuterol or salbutamol for immediate bronchoconstriction. Corticosteroid, they are used to control inflammation during attack, while mast cell stabilizers and leukotriene modifiers are not used for acute, but as part of long-term control strategies, all right? 5 interventions for a patient who has thrombocytopenia. You have to monitor the platelet count and labs. Regularly check platelet levels, coagulation studies like the PT, the INR, and the APTT to assess the bleeding risk. Assess for signs of bleeding, like you monitor for petechiae, bruising, bleeding gums, hematuria, manella, and any unusual bleeding from the puncture site. You institute bleeding precautions, so you avoid invasive procedures unless absolutely necessary. You need to avoid IM injections, rectal temperatures, and urinary catheters. Use soft bristle toothbrushes and electrical razors to prevent gum and skin injury. Apply pressure to the venipuncture sites for longer than the duration, at least 5 to 10 minutes to stop the bleeding. Administer platelet transfusions if ordered. You have to provide platelet transfusion as ordered based on platelet count and clinical status. Avoid medications that increase bleeding risk. So you need to educate patients to avoid the NSAIDs like aspirins, which can further impair platelet function. You educate patient on safety measures, like you instruct the patient to avoid activities that increase the risk of injury, like the contact sports. You educate them also on the fall prevention strategies, like wearing well-fitting shoes and removing tripping hazards in the home. You monitor for neurological changes, like thrombocytopenia normally increases the risk of intracranial bleeding, so you have to assess the patient for any changes in level of consciousness, headache, or neurological signs. You maintain a controlled blood pressure to reduce the risk of bleeding, particularly in the cases of hypertension. And you encourage the intake of fluids, a balanced diet to maintain skin and mucosal integrity, reducing the risk of spontaneous bleeding. You provide emotional support and education to alleviate anxiety about the bleeding risk, ensuring the patient understands self-care measures. Describe the pathophysiology of chronic bronchitis. So in chronic bronchitis, we have chronic inflammation, where the chronic bronchitis usually results from long-term exposure to irritants, most commonly the cigarette smoke, air pollution, or occupational dust. These irritants normally cause chronic inflammation in the airways. Those are the bronchi. This inflammation involves the infiltration of neutrophils, macrophages, lymphocytes into the bronchial walls. Over time, this leads to a thickening of the bronchial walls. Then that leads to hypersecretion of mucus. So chronic irritation stimulates the goblet cells and the mucus glands in the airway lining to increase the number and size. This leads to excessive production of mucus, which obstructs airflow and reduces air exchange. The excessive mucus can become thick and sticky, clogging the small and large airways. This restricts airflow, contributing to breathlessness and the characteristic productive cough of chronic bronchitis. The inflammation at the mucus overproduction normally impair the functions of the ciliated epithelial cells, which normally helps clear mucus and debris from the airways. As a result, mucus clearance is reduced, allowing mucus to accumulate and bacteria to proliferate, increasing the risk of infection. Chronic inflammation then leads to fibrosis. That's the scarring of the bronchial walls, which causes permanent narrowing of these airways. This airflow obstruction leads to air trapping, causing difficulty in exhaling fully, resulting in the classic symptoms of the wheezing, dyspnea, and prolonged expiration. That leads to impaired gas exchange. So this is normal due to the narrowed airways and the mucus plugging. So we have less oxygen reaching the alveoli where gaseous exchange occurs. As a result, there is a ventilation perfusion mismatch, which leads to decreased oxygen levels and increased carbon dioxide levels in the blood. The accumulation of mucus provides a breeding ground for bacteria and other pathogens, leading to frequent respiratory infections, which further exacerbate the inflammation and damage the airways. So over time, chronic hypoxemia causes the blood vessels in the lungs to constrict. This is pulmonary vasoconstriction, increasing the pressure in the pulmonary arteries. This can lead to pulmonary hypertension, placing strain on the right side of the heart. That's the copper pulmonale, potentially leading to heart failure. So the The hallmark signs of this disease will lead to productive cough, which lasting for at least 3 months per year for 2 consecutive years, shortness of breath and wheezing, and frequent respiratory infections. Explain the pathophysiology of acute renal failure related to the prerenal causes and also the intrarenal cause, intracranial causes. So for the prerenal causes, we have hypovolemia, decreased output, cardiac output, systemic vasodilation, and renal artery stenosis. Intrinsic or intracranial causes could be increased ICP, the Cushing reflex, the syndrome of inappropriate ADH, and acute renal dysfunction from CNS injury. Patient is scheduled for barium enema to check for any abnormalities in the digestion. You need to state 4 specific measures taken to prepare patient for barium and set 4 specific post-procedure nursing intervention for this patient. Measures to prepare for a patient for the barium, what you need to do, we have to look at dietary restriction, instruct the client to follow a clear liquid diet for about 3 days before the procedure to reduce fecal content in the colon and ensure clear damage. Others include bowel preparation, fasting, medical adjustments. For the post-procedure, you could monitor the bowel sounds, encourage hydration, and administer laxative if needed, monitor for adverse reactions. Physiology of injective endocarditis, right? We have endothelial damage, that then leads to bacterial or fungal seeding, formation of vegetations, systemic effects, host immune responses, and the complications. Classifications of burns according to burn depth, and also explain how severe burns can lead to changes in the body's fluid balance. Of course, classification of burns according to the burn include the first one we have first degree burns that involves the epidermis, only the epidermis. Then you have the partial thickness and deep thickness. Partial thickness involves the epidermis and the part of the dermis, while the deep partial thickness extends deeper into the dermis. Full thickness, this is a third degree burns, involves the epidermis, dermis, and subcutaneous tissue, while the fourth degree burns involves all the layers of the skin plus the deeper structures, such as the muscle, bone, and the tendons. Jean is admitted to the hospital with the diagnosis of pneumococcal pneumonia. She has intermittent productive cough and has some dyspnea. The parents say that he has been lethargic and anorexic for 3 days. Oxygen saturation at 8 via pulse oximetry. You are told to differentiate between community-acquired and hospital-acquired pneumonia, describe the pathophysiology of bacterial pneumonia, and at least use 3 nursing diagnoses describing the management of Jean. So that's the difference between CAP and HAP. Of course, CAP occurs outside the hospital setting or within 48 hours of hospital administration, right? Often caused by Streptococcus pneumoniae, Haemophilus influenza, Mycoplasma pneumoniae, or the viruses. Typically, no significant exposure to hospitals. HAP develops 48 hours or more after hospital administration, not present or incubating at the time of administration. Common causative organisms include Pseudomonas aeruginosa, Staphylococcus aureus. Pathophysiology of bacterial pneumonia, we have invasion of the respiratory tract by the bacteria, right? That is the Streptococcus pneumoniae. When then it will cause an inflammation response that leads to exudate formation, leading to consolidation, right? Consolidation, and then have now impaired gaseous exchange and possibly resolution. Intervention, nursing diagnosis, you have impaired gas exchange related to alveolar inflammation and exudate as evidenced by oxygen saturation of 80 and dyspnea. Infective airway clearance, related to excessive secretions and productive cough as evidenced by intermittent cough, productive cough, and dyspnea. Imbalanced nutrition, less than body requirements related to anorexia, lethargy as evidenced by refusal to eat and poor appetite. So in summary, in terms when you're looking at genes management in the first 48 hours, you have to ensure there is oxygen therapy, and positioning will help her at least gas exchange and reduce hypoxia. You have to carry out chest physiotherapy, give humidified oxygen and mucolytics, which will help with airway clearance, relieving her dyspnea. And small and high calorie meals and IV fluids will support her nutritional status and address her lethargy and anorexia. So here you are requested to describe the pathophysiology of liver cirrhosis, complication associated with liver cirrhosis, typical medications used, of course, in management of liver cirrhosis, and specific nursing intervention for a patient who has undergone paracentesis procedure. Of course, pathophysiology of liver cirrhosis, we have the chronic liver injury that leads to inflammation and hepatocyte death. Then you have fibrosis and scar tissue formation, nodular regeneration, portal hypertension, and impaired liver functions. Complications, we have ascites, esophageal varices, hepatic encephalopathy, and coagulopathy. Types of medication used in management of liver cirrhosis, we have diuretics like spironolactone, which is normally used to manage ascites by promoting excretion of fluid through urine. Beta blockers like propranolol, which reduces portal hypertension and decreases risk of esophageal varices bleeding. We have lactulose, which is normally used to treat hepatic encephalopathy by reducing the absorption of ammonia in the GIT, thus lowering its levels in blood. Vitamin K or blood products, which are given to correct coagulopathy by supporting production of clotting factors or replenishing lost blood components during bleeding events. Specific intervention, you monitor vital signs, assess for signs of bleeding or infection, measure abdominal girth and weight. Those are some of the specific functions after undergoing paracentesis. Remember, these are our topic 1 testings. So we can be tested on either of the listed topics.